Hi, everybody. I'm Dr. Carla Rodriguez. I'm an adult congenital cardiologist here in Puerto Rico and University of Puerto Rico. I'm an assistant professor and also works at the Centro Cardiovascular de Puerto Rico and El Caribe. I'm also part of the JACC ACHD Consultants, and today I have the honor to interview Dr. Lidija McGrath. Dr. Lidija McGrath is an adult congenital cardiologist as well. She's an assistant professor at Oregon Health and Science University, and she also is the ACHD Fellowship Program Director at Nye Cardiovascular Institute. So, Lydia, thank you so much to joining us.
Thank you, Carla, for having me. Hi, everyone.
Dr. McGrath, why from the early career perspective?
As an early career ACHD cardiologist, I think our perspective is unique in a sense that when we first start practicing, we really rely on the guidelines as a really valuable decision aid in clinical practice. And I've done this with the 2018 iteration of the guidelines and now with the 2025 iteration where, in clinic, before seeing a patient, I have the electronic health record on one screen and the guideline document on the other. And it really helps me solidify my clinical decisions. It helps with patient shared decision making. So it's a really valuable tool, particularly for early career clinicians as we start our independent practice. And then in our teaching roles, I use the guideline document also for teaching the residents and medical students and fellows. There's really nice flow sheets and tables that we can incorporate into teaching. And I think that's another really important role for the document.
Definitely. And going a little bit more deep in the guidelines and now this update, what do you think is the most meaningful change to these guidelines in terms of ACHD systems of care?
I think one of the most important things is this alignment of the recommendations with system level realities. What the guideline now does is really kind of consistently acknowledges that not all ACHD patients are going to be able to receive care in specialized ACHD centers by board certified ACHD physicians. And it really kind of emphasizes that we can really integrate and share our knowledge and partner with local cardiologists in more rural communities. So it acknowledges that we can do that more specifically now.
Definitely. And that takes me to what about for these guidelines in cardiology that do not receive and formal ACHD training because live in another place or they don't have the training but don't have any ACHD cardiologists close by. What do you think these guidelines how they can help them?
It's really important for people to familiarize themselves with the AP classification that was initially introduced in the 2018 guidelines and has now been further expanded in the 2025 guidelines, because it really gives providers a lot of insight as to why ACHD patients are so unique and why two patients with, the same anatomy, the same anatomic diagnosis can have such vastly different courses. And when we think about delivering care to these patients, not every patient is going to be able, again, to access specialized ACHD care. And depending on their anatomic and physiologic classifications, we can partner with those cardiologists or clinicians who are not ACHD trained and really empower them that, yes, they too can take care of these patients. Sometimes it may take a one-time visit with an ACHD cardiologist to develop a really comprehensive treatment plan. And then individuals who practice in rural areas or who practice general cardiology and will see these patients, they can really feel empowered to taking on that care of that patient. I think it's, the lesion-based approach is really convenient as well. So if you are practicing in an area where you don't have an easy access to an ACHD specialist, you can look at, for instance, the lesion being VSD, and you can really make sure that you're following the guidelines, that you use the flow sheets and the table. So it's a really easily referenceable document for, not only ACHD cardiologists, but also for those who do not have that specific training.
Definitely. And I think in your commentary, one of the things that you mentioned about the figures and tables, and definitely I think that it's very easy to follow those, and for those especially that are not so familiar to all of that. So that I totally agree with that. Changing a little bit of the topic, I know that transition, obviously, to us, adult cardiologists and adult congenital cardiologists, it's a big topic always because it's a challenge in our practice. How do you feel that these guidelines can help to solidify more what is transition of care and how this will improve outcome if you think that will improve?
Yeah, I think the guideline really nicely emphasizes the importance of transition and how critical of a time that is for patients. And there's a couple of very key recommendations that I think will help with improving the transition outcomes. One is really emphasizing that process should be started early and that transition really is a process rather than an isolated, time event. That time event of transfer, requires a whole process of transition before. And the guidelines emphasize the need for starting that early and for it to be age appropriate, gender appropriate, developmentally kind of appropriate for patients. So everybody's going to be on that trajectory in a little bit of a different way. The other thing that the guideline does nicely is it integrates things like, or emphasizes that we need to integrate things like mental health, neurocognitive assessment, social complexity, because vulnerability in the transition process is rarely only cardiac. There's a whole lot of things that go into it. And then we can engage the appropriately qualified personnel. We can make sure that we have systems in place that will allow us for that process to go more smoothly. And I think the guidelines really outline all of those aspects pretty well.
Definitely. And now going through those of transitions and gaps in care and equity, do you think that the 2025 update of the guidelines, this update helps in address more what is equity in access in ACHD care? And where do you see that these guidelines can improve also the outcomes of that in this population that is more vulnerable?
The guidelines do acknowledge the resource variability, and they do acknowledge, they speak to that fact that not everybody is going to have equitable access to high quality care. And I think they've adjusted some of their tables to reflect that. So that is it's an important acknowledgement. They do, mention partnering with rural or under-resourced settings, and again, collaboration with the local teams. And they do mention disparities related to race and socioeconomic status and insurance barriers. They do mention those and acknowledge those, but they haven't really directly addressed them from a solution-focused approach. So I am hopeful that as we learn more about this topic, as we acknowledge this topic more and study this topic more, then in the future iterations, we will be able to have, that more as a quality metric rather than just a contextual challenge. So that is something that I'm looking forward to exploring more.
Definitely, that's true. Always, I think that especially in places, as you mentioned, where we do not have all the resources, as me here in Puerto Rico, we have mostly of them, but we are a small island, so it's a little bit harder sometimes. Definitely, I think that this guidelines will help to guide a little bit more in terms of partnering with our local cardiologists and all of that. So definitely. Now talking a little bit more, especially as you are a program director of one of ACHD programs, I would like to ask you how you think this 2025 guidelines can help our trainees in terms more like research opportunity, investigation opportunity, or either us as an early career, how we can, this guideline can help us to maybe address some topics more that now they are more specific in certain things and there are more data.
Yeah, I think the guideline does a really nice job really emphasizing where the evidence is strong, and then also acknowledging that there are still a lot of the gaps in the evidence when it comes to ACHD patients. And I think they also nicely outline those gaps. So those tend to be kind of good opportunities for research for some of our trainees, answering a clinical question. A lot of the guidelines are also based on surveillance. And when we have a recommendation about surveillance imaging, that also can become a good scholarly project for trainees. The other thing that the guidelines emphasize that I think can be helpful for trainees is this collaborative approach and development of multidisciplinary clinics, for instance. Cardio B is one of those examples, or a Fontan heart failure clinic. And, as people enter the field of ACHD, there is a leadership opportunity there as well to develop these programs, to develop these clinics. And then as you engage more with the guidelines, you tend to recognize names of people who write the guidelines and, major societies who endorse the guidelines. And ACHD is still a pretty small world. So I think mentorship and collaborative relationships can happen from that perspective as well.
One question that I have is, I think when I read the guidelines, they still take more points and address few things that actually before we didn't. Now the AP classification have more information where you can start to classify more a patient that maybe you were not so sure were, especially in the physiologic part. Do you have any other highlight that you would say maybe this is a gap in the guideline that maybe we are going to address, as you mentioned with the Fontaine and maybe estrogen therapy? I think that for one side, there are more specific things that they address, which is great. And then there are others that obviously, as medicine is still in developing and more information there is available about hormones and all of that. What do you think we should address more in the next guidelines, maybe?
Yeah, I think that's a great question. I think you brought up the Fontan, and in general, I think providing gender-affirming care to some of the more complex lesions where you might have considerations about hormonal therapy. I think exploring that further is going to be really important so that we can provide the best gender-affirming care that we can in a safe way and in an effective way. So, further exploring that. I think the guidelines do touch on nicely on the importance of mental health and neurocognitive assessment, and again, supporting patients where they're at from that perspective. But further elaborating on that is going to be really important. And then similarly, as they do emphasize the importance of transition from pediatric to adult care, I think one of the areas of future studies and more emphasis is going to be that transition from, your adult care to end-of-life care. So including things like palliative care, shifting the focus towards quality of life, towards the end of life, and studying any type of interventions and outcomes of how we can best serve our patients, particularly in that transitions towards later stages in life. One other thing I'm interested in is exercise and physical activity recommendations, and really kind of personalizing those a little bit more depending on their anatomic and physiologic classifications. I think that would be nice to see as well.
Perfect. Is anything else that you think that we should mention now? I think that we have talked a few things and definitely highlight several things from your commentary that were great. Anything that you would think of you would like to mention that I haven't asked you?
I think we've touched on the most important things. I think really it is such a wonderful document. It's been really nicely updated. I love using it in clinic every day. I love using it in teaching. I love using it in my scholarly work. So it's really, I think, applicable so well to so many different kind of levels of what we do. And the expanded AP classification, I think, is really one of the highlights. And then before I forget, really the linking of the why, right? So you have all these recommendations, and then for every recommendations, there is now a why statement. Why are we doing this? And that is a really nice and very welcome update from the prior iteration of the guidelines, because when you have these shared decision-making conversations with patients, it really matters whether we tell them, why we're doing this. We're doing this to help you feel better. We're doing this to help you live longer. We're doing this to prevent adverse events. We're doing this to prevent sudden cardiac death. all of those reasons behind the why, I think, are very nicely highlighted in this document. And I think that really adds to our, shared decision-making and with patients. So I love that update as well.
Well, I'm going to say, Dr. McGrath, thank you so much for joining me today and definitely share your expertise with me and with us today. I just want to say thank you, and thank you to the ACC, JACC, and JACC consultants to make this invitation.
Thank you so much for having me.